shows. Typically, the homegrown movies tend not to be great. Folks on YouTube, you are behind the scenes. We're yet to go live here to our Zoom audience, but you're behind the scenes with our esteemed panel. Bear with us. We're going to go live in about 15 seconds. All right, folks, we're going to go live. I'm going to let our folks in. I'm going to start it up right now. Have fun. Greetings, everyone. This is Eric Glazer, and welcome to our latest live recording and episode of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform you, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations around our nation. Our goal is to identify as many bright spots as possible so you can determine if the ideas shared on this episode can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. For those new to the show, and if you are, I encourage you right now to go onto your tablet, find Bright Spots in Healthcare in your podcast app, and subscribe. That way, every single episode, whether you're watching it live on Zoom or you just happen to be traveling, I can't be here at 12 o'clock on a Thursday, you will get those episodes downloaded to your device within 36 hours of our live recording. You can also access our video version, video recording of this episode on our YouTube channel and wherever, and on our website, sharedpurposeconnect.com. Final administrative announcement. At 45 minutes past the hour, we're going to send you another email. I'm going to send you another email just asking for your feedback, not only on this show, but what other content we should be covering throughout the year. This is our way of ensuring that every hour we produce for you is an hour well spent. And that's really important to me personally and my entire production team to make sure we're covering relevant topics. So we take those surveys seriously. And I think it's a big reason why we've been able to grow the show like we have over the last couple of years. Our sponsor for today's episode, which is entitled How Digital Technologies Are Advancing Health Equity, our sponsor is Healthy.io. They are at Healthy.io. They are one of our longest standing partners, and they are an innovative healthcare company that uses smartphone technology to make remote clinical testing possible. And I will give you more details on them later on in the show, but you can certainly check them out now at healthy.io. We have a great roundtable of experts for you today who will share with you bright spots and ideas, and we have incorporated many of your questions that you submitted upon registration into our planned conversation. And with any luck, we'll be able to take a couple of questions live from all of you using the Q&A module, please, in front of you on Zoom. Do not use chat to ask questions. It's much easier for my production team and I to review them via the Q&A module. We'll bypass bios as we always do for our live audience, but we will provide you a clickable link in the chat so you can see all of the information around these three great panelists and the great expertise you're about to benefit from. All right, let's get started. I want to get into examples around bright spots, and we will focus the vast majority of our conversation around that, the how, and a little bit about the impact. But first, I want to start around prioritization, because I think everyone who's on the call today, small organization, large organization, a lot of competing priorities, lots of talk about social determinants, virtual and digital care, and health equity, how to go about setting priorities around health equity and last mile care. So I want to go around the room. We'll start with Seun, then we'll quickly go to Paula Gutierrez and then Paula LeClair. How does your organization go about setting their priorities around health equity? Seun, why don't we start?
Oh, thanks. Sorry about that. Thanks, Eric. And I appreciate you having me on the show. Health equity is a top priority at Independence Blue Cross as part of our corporate strategy. Last year, along with the 34 other Blue companies across America, announced a national health equity strategy to confront the nation's crisis in racial health disparities. It's a multi-year strategy that focuses on 4 conditions that disproportionately affect communities of colors, and those are maternal health, behavioral health, diabetes, and cardiovascular conditions. And as the executive director of health equity, I'm leading that work creates and defines measures of equity and improvement for all independence lines of business. And to that end, I have a few priorities: holding us accountable for data-driven improvements, benefits and care delivery redesign, community engagement and investments, population health and digital health, and academic community collaboration. Our work relies on close collaboration with providers and the local community. And so it means that we are addressing implicit bias and lack of cultural awareness in healthcare and looking for ways to close gaps and rethinking how the system cares for our members. And all of this is underpinned by data. Data is foundational to everything we do. Historically, payers did not ask for race, ethnicity, language, sexual orientation and gender identity data. And then up until this year in Pennsylvania, it was actually illegal for us to do so. And so we've lobbied the state to change that law. At least they won't be enforcing that law. And so now we're literally off to the races to learn what the data shows. But that is how we defined our priorities in health equity.
Thank you, Sean. So I've got one of my producers, Gene Ware, on behind the scenes right now because I'm training him to potentially co-moderate with me from episode to episode. One of the biggest mistakes you can make, Gene, that you shouldn't make is introduce your first question without telling the audience the title and affiliation of your guest, which I just did. So I want to, Sean Ross is the Executive Director of Health Equity at Independence Blue Cross. Sorry about that, Sean. All right, let's get our next expert's perspective, and that would be Paula Gutierrez, and she is the Director of Health Equity for CVS Kidney Care, which of course is a CVS health company. So how is CVS, Paula G, going around health equity and prioritization?
Thanks, Eric. So thank you for the introduction, and Sean, great segue. So CVS Health actually hired its inaugural Chief Health Equity Officer, Dr. Janae Caldoun, in October of 2021. And her strategy is really centered around heart and mental health. She's calling it our Hearts and Minds Promises. So for us within CVS Kidney Care, we're sort of dovetailing into that strategy. So CVS Kidney Care is a relatively new business to the broader CVS Health family of companies. We've been around for about 4 years. And when you think about kidney disease in America, it's sort of the poster child for health inequities. It's a disease that unfortunately disproportionately impacts communities of color. So CVS Health made the investment in CVS Kidney Care to really change the way in which kidney care is delivered in America. So when we think about this for us within kidney care, health equity, of course, is my responsibility, and I co-lead this with Dr. Jesse Roach, who's a nephrologist formerly from Medicare. And we think about this not just as our responsibility, but really that it's everybody's responsibility. It's a shared responsibility and accountability across the entire CVS Kidney Care continuum. So we're really looking at leveraging existing assets from the broader enterprise to help us achieve those goals. But our focus is very much centered on social determinants of health and looking at the data around that to help us inform those interventions. So our strategy is very much data-driven, looking at where the gaps are for our patients and our members, and then come up with thoughtful solutions and interventions to address that, especially when we think about, I know a lot of the work in this, for bright spots is around that last mile care. A lot of our work is centered around how do we get to people that can't get to us? And that's where leveraging our broader footprint comes into play, especially also with looking at things like transportation, individuals that have kidney disease and can't get to their dialysis appointment. We see a significant non-adherence rate because they can't get there. So looking at interventions around that, but also food. Food is an incredibly big part of our strategy, and providing interventions around addressing healthy eating, fresh foods, healthy foods, especially in food deserts, right? Another segment of the population that is oftentimes left behind. So how do we get to them? So we're looking at investing in interventions around those key areas to help us really change the paradigm within kidney care in America.
Thank you for that. And so Paula LeClair, Paula's the U.S. General Manager at Healthy AO, and they're a health technology company. So how does one that supports the rest of the industry with product development, how do you go about setting priorities around health equity and last mile care?
Thanks, and thanks for having me, Eric. And I'm glad Paula G went first because I'm going to dovetail nicely into some of the things that she said. But as Eric mentioned, at Healthy IO, we are turning the smartphone camera into a medical grade device. And by doing so, we are putting basically a clinical device at the hands of everybody who owns a smartphone. And there's lots of things you could do with that. So we interpret color, and we're trying to change the pathway for routine screens or tests or things that can be done with color, which would lead you to urine dipsticks. And then within urine dipsticks, there's all kinds of tests that we could have launched first here in the US, and we hope to bring them all. But we decided to focus on kidney disease screening because, as Paula mentioned, it does affect Black Americans 4 times more. People are not able to get to the lab, and this is even before COVID. And 37 million people in the US have kidney disease, and only about 20% know it. And even worse, people aren't being screened. So we know that about 80% get a very important test, which is to look for albumin in the urine. They don't have transportation. They're not going to the labs today. And so with a simple camera, our app, and our kit, somebody could screen from home, get a screening result right to their phone, as well as education. So we've partnered with the National Kidney Foundation. We've also partnered with the Texas Kidney Foundation to bring our kits and to use their content so that we're speaking in their language about kidney disease. So we look at the need in the market, and we'll continue to prioritize other products after this one.
Great. I'm going to do a quick change in order as far as I'm just telling my roundtable folks around. So I want to get to some examples, then we'll get into scalability. We'll flip-flop those questions. So what I'd like to do next is, Seun, can you provide an example of how Independence Blue Cross is thinking about and approaching health equity programs? And then I'll ask Paula the same thing. Paula G.
Sure. So I think, at Independence, a team of my colleagues, and we have a department called the Clinical Care Transformation and Innovation Department. They find these solutions, pilot them, and once it shows positive outcomes, we scale it to our 8.1 million members in 26 states and in DC. And a good example of that is a foot mat from Podometrics. It is a mat that diabetics would stand on, and it can predict. I'm trying to make sure I have the numbers right. It can predict 97% of foot ulcers on average 5 weeks prior to clinical presentation. So that means that before you even see anything on your foot, this mat can detect it. And that the way it works is, we send it to our member who is a diabetic. That's part of their criteria. They stand on the mat. They only have to stand on it for 20 seconds. It is digitally transmitted to a care team. That care team measures the foot temperatures and other things, and then communicates with that patient those temperatures, or if there is a potential problem, and then make sure that member connects with their primary care physician. And so in that way, because of the cost of diabetic foot ulcers, it just prevents all of this negative sequelae and all of these unwanted healthcare outcomes. So that's one. The second one that I would mention is Heart Safe Motherhood. It is also digital, is text-based, where we are monitoring birthing person's blood pressure to ensure that they don't progress to a preeclamptic or eclamptic state. And we know that 75% of maternal deaths are associated with hypertensive disorders. And so these are 2 programs that we have piloted and will eventually be scaling across to all our members, and which inevitably translates to the community at large.
So Paula Gutierrez, what about CVS Kidney Care? And I guess specifically, I'd love for you to provide some details, one around what you're doing with home dialysis and how you're approaching that from both from a health kind of equity, and then maybe how you're addressing the digital literacy or home care literacy gaps prior to implementing your solution.
Sure, Eric, thank you for that. So, the creation of kidney care was actually pretty interesting because for those that I'm sure are familiar with the kidney care landscape in America, it's pretty fragmented, it's pretty siloed. So our intent is to bring all of those pieces together, in particular, trying to really encourage the increase in home hemodialysis, right? So it tends to not be prescribed as often as in center, but we know in some respects that there are better clinical outcomes when folks use home. So one of our programs is our home-based care training program. So what we're looking with this is to really use virtual care and our local CVS stores to really minimize the need to commute to a clinic. And in addition to that, that also sort of expands the number of people that are actually eligible for that because they're doing it in their home. So we can support them, we can support, and also detect some of that burnout that often happens when individuals are on dialysis, but also really encouraging and helping with medical supply delivery, digital engagement. For example, one of the things that we're doing is providing in-home and digital training for home hemodialysis. And what we're trying to do with that is also ensuring that the training is happening with individuals from those communities that reflect the population that we're serving, right? Because if you think about someone having to come into your home to train you on home hemo, which is very, it's a lot. We want to make sure that the people that are coming in look like the community that we're serving, and also, to your point, Eric, understand the culture, but also understand the language. And conversely, with that continuity of education and training, there's also a digital component. So the patient will be provided a tablet for e-learning, condition management resources, and different virtual tools to connect with dialysis team, care, and physicians. And it's going to be available both in English and Spanish to account for the population that is impacted. As Paula said, it is a disease that disproportionately impacts both the Black and the Hispanic community. So those are just some of the tools that were the programs that we've invested in for kidney disease.
That's great. Just a PSA for everyone. If you want to ask follow-up questions or help me co-moderate that Q&A module at the bottom of your Zoom interface, you can submit your questions there. So Paula, LeClair, so we're thinking about digital literacy and training, but a lot of the key to the success and adoption of services and products that go into underserved populations is all around product design and making sure it's truly human-centric. So how do you see plans and providers leveraging a human-centric approach to developing technologies for underserved populations?
Thanks for the question, Eric. First, I think keep it simple. So in our case, it was, can you take a picture with your cell phone? So we don't want to take too much data up because members may have small data plans and they may not want to use that to communicate back and forth around their health. We want to keep it ubiquitous. Cell phones are ubiquitous, so make sure the technology is available to the masses. Multilingual, I know Paula just mentioned that, as well as Sean. So we want to make sure that we provide the same language, the same culture. So staff the call center appropriately to where you're going to launch. Also listen and get feedback. So I'll share a quick tidbit. We went out with a video that said, here's how to do the test kit and be done. And guess what? The majority of people don't watch the video start to finish. The results were nowhere near where they would have needed to be. And we quickly changed it to an app to account for some people need to go slower. So the app will walk you step by step by step. But if you're taking the test for the second time, we know that, and we can actually skip some of the steps. So making sure that you're collecting that user feedback and then building it into the product.
Sorry, my mute button stuck. Yeah, it's great. So I want to circle back to Paula Gutierrez and talk about scalability. So big health organization like CVS Health, how are you creating a scalable approach to reducing health disparities at a community level?
Yeah, so the great thing about CVS, right, is that we have such a large footprint. And I think we're in a very unique position for kidney care to really change the way that care is delivered. I mean, if you think about it, we reach over 100 million people through Aetna, Caremark. So it's a really huge opportunity for us to improve the trajectory of kidney disease. And we can pull sort of multiple levers within that continuum to transform kidney disease. We're guided we're guided by our consumers, and Paula just alluded to listening to that community aspect. We're guided by our consumers and trying to really create a personalized experience. We have a great experience team that helps us do that much more intentionally and thoughtfully, and we can connect them with those solutions to really reinvent how kidney care is accessed and delivered. So, we have an opportunity to really make what I like to say a seismic impact in changing the kidney care landscape, and we're uniquely positioned to do that. So in terms of scalability, I think we're very different from others in the market that we can do that, and we have the different assets to do that others may not.
Let me ask a question around from the audience, and I'll start with you, Paula L. But then I would love Sean and Paula G, if you have comments on it, to jump in. With all the use of the technology, how are you accounting for the cultural differences that may inhibit communication or adoption?
So for us, we do know that we take our data and plot it on a heat map. So super proud to say that we get the same uptake, which is about 40% of people doing the test, or not, if not more, that we send it to. And we don't see differences if they're in an underserved community or not an underserved community. So again, building around a ubiquitous device like a cell phone, accounting for languages in the app, so English and Spanish for now, as well as we call them patient engagement advocates who come from the community that are there if the test can't be done on their own or somebody has a question. So we're actually, and we do track that. As I said, we put every test on a heat map to make sure that our product, our solution, our training materials are being used by all different zip codes, parts of the country. And to date, we've been able to do that.
Paula or Sean, Paula G or Sean, do you anything to add or to that, or you're good? How are you using technologies?
I'd say, for example, with some of so we're in a couple of different markets, and what we've done when we sort of develop different products or services is that we look at those markets, right? So what's going to work in, before the call, we were chatting about where we're in. I mean, I'm in New Jersey, you guys are up in the Boston area. What's going to work for one community isn't going to work for another. It's not a one-size-fits-all solution. And that's sort of the beauty that I have, along with my colleague, Dr. Roche, is that we're embedded into all different parts of our business within CVS Kidney Care, so that we can ensure that whatever solutions we're developing are with an equity lens, which includes cultural sensitivity, language, health literacy, right? And even something as simple as the marketing materials that we're creating, right? That they align with and connect with the different populations that we serve. So, that's sort of how we've been approaching the cultural lens, which is crucial to trust community, because if folks don't see that, and they can't see somebody that looks like them, understands their culture, speaks their language, they're much less likely to use whatever it is that you're offering. And then ultimately for us in kidney care, we want to really empower our members and our patients to with their kidney health. So we want to ensure that we're connecting with them in the way that they want to be connected, and just not the way that we think they should be.
Yeah, and I agree with my both panelists, both Paulas, that we did the same thing. I think we chose we needed a structural catalyst, which was the NCQA accreditation on health equity, and we're going that route, right? And part of that is ensuring that we are able to communicate with all of our members in the language that they're most comfortable communicating with. Also, ensuring that all of our providers can meet the patient in their home, and that is through digital technologies, right? And so we went from like 200 and something thousand telehealth televisits to over 2 million in 1 year. And so that is, it is just rapidly scaling from in-person care to virtual care.
Great. Seun, I want to get to examples again. So I have an example question for you. I want to, but just a little quick, digression, or I want everyone to know we're taking a couple weeks off as far as live episodes go. Our next live recording, though, is related to this topic. It's going to cover reducing chronic condition readmissions and transition of care. And it'll focus on all things chronic condition and transitioning an individual out of an acute setting to the home or to a rehab or longer term care facility. So if you want to join us live and don't want to go through the registration again, we're going to put up a poll for you. It's Thursday, July 21st, 12 p.m. East Coast time, 9 a.m. On the West Coast. If you want to attend that live recording, which will be our next one, Thursday, July 21st, just click on yes, and we'll take care of registering you. So Seun, could you, we talked a bit prior to the show about how health plans are destined to be less effective if they think they could be on an island and attack health equity effectively, and thinking about all the different players that need to be involved in the effort. And I'd love if you could provide an example of how IBC, Independent Blue Cross, is thinking about and approaching health equity programs and partnerships.
So to your point, I think that, right now nationally, there are 25 centers of health equity, with lots more popping up since health equity has become part of the national conversation. And to date, the disparities, the inequities in healthcare are getting worse. And so what Independence realized was we cannot do this work alone. Our work has a three-pronged approach. I mentioned we thought it best to use a structural catalyst like the NCQA accreditation on health equity. And our three-pronged approach is what we are specifically focused on for our members, which I mentioned earlier. And then there's the work done by our philanthropic arm, the IBC Foundation's Institute of Health Equity. And then third, we're part of a new region-wide initiative called Accelerate Health Equity. And this is really an exciting effort that produces real measurable change in health disparities. It's being spearheaded by over a dozen influential organizations in the Philadelphia area, like AmeriHealth Caritas, CHOP, Philadelphia Hospital for Children's Hospital of Philadelphia, the City of Philadelphia, Drexel University School of Medicine, Jefferson Health, Mainline Health, and Penn Medicine, the Philadelphia College of Osteopathic Medicine, Temple, and Trinity Health Mid-Atlantic, all of which are supporting and evaluating evidence-based interventions to fight racism and to improve the health of Black Philadelphians. And it's focused on a wide range of topics, from primary care to mental health to digital access, the impacts of violence on health, housing, and food access. And through Accelerate Health Equity, we are identifying solutions that have the most relevance to those communities and the most measurable outcomes, which means it has the greatest opportunity for scale and impact.
Great. So that's a lesson learned of taking the extra effort to partner with community-based organizations to ensure that you're connecting with folks from in the community to be able to deliver true solutions. You can't probably be successful without that. I love that. I love that approach. Paula, LeClair, I want to I want to understand a little bit like how and why is your what I'll call last mile diagnostic so successful versus the abundance of all the other home tests and all the challenges around literacy and education and cultural differences. Like, so how do you, I guess in a nutshell, how are you approaching product design to enable all this success?
Terrific question. So the first thing is that the product itself, what really I think separates us is lab testing has come a long way. So it used to take weeks. We had to get an appointment, go to the doctor's office, wait for the results. And then it got reduced to days because now labs and other companies will send the collection cup home. But you still need to travel to bring that cup to the mail office or put it in an envelope, and there's lots of steps. And we've taken all of that out by designing a process where you'll collect the sample at home, dip the stick, use your cell phone, and wait 2 to 3 minutes and get a result. So I think we are a culture of, what have you done for me in the last 5 minutes? So I think the need and the want to have the result immediately is there. I think it activates and motivates members because they have something actionable. They've done it, and they've done it themselves, and now they have instructions. And it may be as simple as your test was normal and do it again next year. It might say your kidneys could be at risk. So we're never going to send a message saying that you have CKD. We're a screening tool. So I think the way we write those messages is really important. And they are tailored by geography, by age, who we're rolling out with. So we've learned you speak differently to somebody who's 80 versus 26. So we do tailor all of that. I think also important is we're very humble, and we realize that people may not have heard of Healthy IO yet. So we do everything through our partners. So if we're partnering with a health plan, they're first. So we're co-branded, but the shipping box itself will have the health plan logo. So it could come from CVS Kidney Care or IDC, but it would not come front and center from Healthy IO. So we work very tightly with our partners on what's the best way. They're your members, right? They're not our members. So what is the best way to communicate with that member? And how do you think it will work best for them? So the packaging is really important to us. And again, making sure that it's the brand that that person is going to trust. And then when all else fails, we have a patient engagement center. And we've learned through that center who's more likely to test in the morning. We actually have it by age, by geography, who's likely to do it after work, who's not working. We know for sure that seniors are going to talk to us for 12 minutes versus somebody in a commercial plan that's probably going to give us 3 minutes. So we've tailored all of that by age, by product line for the health plans. And then finally, I think communicating urgency. So this fear of missing out, we found out, is real. So as you send messages that the program's ending, we can almost predict what will happen in the next coming days. So I think all of those things, and as I mentioned, the upfront app design. So we have over 5,000 reviews on the app stores that we don't ask for. And we now have people thanking their health plan. So thank you, health plan, for sending this to me. I think the last one, we were like a 4.8 or 4.9. So we read every one of those, good and bad, and learn from them. So the immediacy, doing it at home, all of that plays into again, we're getting better than 40% of these kits actually done.
So this is important, and I want to make sure I wrote down while you're talking 6 key things. So keep me honest here, maybe 7 if you count number 1. So number 1 is it's convenient and actionable. So that's how I wrote down when you were talking. 2 is immediate results. That's obviously a human characteristic. We want immediate satisfaction. 3, brand it with your partner, the one that's has the more close relationship with the individual. So partner branding was number 3. 4 is to focus on patient engagements through behavioral understanding of healthcare persuasion. You mentioned Medicare population, maybe on the phone with you for 12 minutes, another commercial 3. And then the last 2, you said create a sense of urgency. And then the last one, which I don't think should be understated, is really need to focus on the UX. And you mentioned the App Store reviews. Did I capture all that?
Yeah, I would even say on the UX, we've gone as far as we did a Native American population, and we have a video in the app once you get your result. And it was our physician in the video, and we realized that we should go actually to the tribe, film one of their physicians. So all of that goes into the importance. And I think probably the last one is the patient/member knowing something will be done. So knowing that that result is going back to their PCP if they have one. If they didn't give us a PCP, it will go back to a care manager. So I think them feeling that now they have a result, but it's not going to just sit at home with them.
Actual. Yeah, I like that. All right, I just added that. Knowing there's a real action plan behind the results. So I want to get into ROI and ROI planning. Before I do, I think this is a good a good opportunity just to interject. I told you I was going to tell you a little bit more about Healthy IO, and I think you've heard a lot, but this is kind of a cool little thing we're going to do today. We've never done this before. So first of all, Healthy IO, if you join us late, is a global leader in turning the smartphone camera into a clinical grade medical device for at-home urinalysis and digital wound management. And their smartphone powered kidney test aids in the detection of chronic kidney disease and helps close those gaps in access to care for over 500,000 people worldwide. And they've been featured on CNBC, Fast Company, and they've partnered with the NIH in the UK, which is obviously in some of the US's biggest health plans because the test is easy to use and everything that Paula just said. What they're offering to everyone who's listening live here is an opportunity to get a free test. So if you just want to see how they package things, you want to see how it's designed, even if you don't want to use it as a test itself, which you can do, you could request a test and they will mail it right out to you for no charge just to check it out. So we're going to put up a quick poll. If you want one of those tests mailed to you, just click yes, and then we'll follow up, get your corporate or personal mailing address, and Healthy IO will send you out a free test. And if you're listening on the podcast, just go to sharedpurposeconnect.com/healthy, sharedpurposeconnect.com/healthy, and you too can request that free test. All right. I want to get into some ROI talk. By the way, folks, I see the questions coming in. Get them into the Q&A module. Do not put them in the chat. They may not get picked up by me if they're there. So one of our guests asked, is the primary driver for this work ethics, or have you conducted an ROI on this work? So I understand sort of health equity is relatively new. Those of you in the business know a new program, a new product, a new service sometimes takes 5 years or more to get enough and to understand what the return is on that program, on that investment. So I'm going to ask Paula first, like, how are health plans planning? So that's the key word, planning to measure ROI on health equity and last mile investments.
Yeah, thanks, Eric. So we really need partners from health plans to really share some of this data, because actionable data allows us, and strong partnerships allows us to yield healthier communities. So if we can't measure it, we can't change it. Data really allows us, to offer services that might prevent and manage and really fight back against kidney disease, at least for us, within kidney care for every person in our community. I sort of joke around and say, I've been doing this work before it was sort of the cool thing to do in terms of health equity. And it's not only is it the right thing to do, but there is a business imperative behind it. And I'll share 2 examples of what kidney care is doing around this work with a pretty direct ROI attached to it. And I think somebody asked a question about this in the chat, but one of the biggest barriers around social determinants of health for kidney patients is transportation. In one of our programs, we noticed that there was a significant non-adherence rate to adherence to dialysis treatment. And we went back and looked at this data more deeply, and we found that it was tied to transportation. So we're looking at exploring a transportation intervention with this particular community that is a population that there is no public transportation infrastructure. So, we need to rely on things such as Uber or Lyft, but, transportation is a real barrier to many communities, especially end-stage renal. So getting them a ride won't only increase their adherence to their dialysis or medical appointments, but it results in better outcomes, right? Which reduce readmissions, reduce hospitalizations. That can, of course, drive very expensive costs. I mean, if you are familiar with patients with kidney disease, we spend almost 1% of the U.S. federal budget to cover dialysis. So investing in SDOH, investments such as these, like transportation, are definitely going to definitely have an ROI attached to them. One of the other programs that we have that we've been exploring is around food. And many of you may have heard around programs around food as medicine or medically tailored meals. So in this same population that I just talked about, it's actually in Texas, there is a segment of the population that lives in a food desert. So they don't have access to a grocery store, so let alone any kind of healthy kind of meals. So we're looking at another partnership with a company that addresses and can provide medically tailored meals for chronic kidney disease and end-stage renal disease patients. And it's designed with that equity lens. It was a company that was started by a woman that was in tech that ended up with diabetes, and she's a Black woman and didn't know how to, had no idea how to eat healthy. And she said, I need to figure this out because I'm sure I'm not the only one. So has this very successful business that we're looking at partnering to have those medically tailored meals as a pilot program for some of these individuals that are food insecure and have very restricted diets, right? Potassium, protein, fluid intake is something that we need to be very mindful of with the chronic kidney disease and end-stage renal disease population. So that's, data from this program is certainly going to help us deliver and duplicate and scale programs like these, but also address other targeted interventions for different communities with different needs.
Seun, I don't know if you want to comment, but I think, I'll take a question directly from the audience member. That would be a good follow-up. Are plans sending tests home to every patient or just at-risk patients or patients that have requested it? Because she thinks, why would you spend money to do this unless there's, a business driver to it? So have you guys figured that out? Are you looking to figure that out? Or are you doing it because just fundamentally your CEO thinks this is the right thing to do?
I would say that fundamentally our CEO believes that this is the right thing to do. I think that it is, when we talk of ethics, right, it is ethically for us, ethically, we are determined that all our members are the healthiest that they can be. This is, that's just a fundamental outlook that we have for all of our members. Now, when it comes to whether or not we're mailing test kits, like for example, we have a partnership with the Colorectal Cancer Alliance because we know that people, particularly Black men, are dying disproportionately from colon cancer. We're mailing it out. If we have all of these algorithms, right? These engines that help us find the patients that are at risk, whether it's due to age, whether it's due to race, whether it's due to environment. Based on your risk factors, we're mailing you these test kits for free because we want people to be healthy. So that's just a quick, short answer, that ethically, we want people to be healthy, period.
Great. I'm gonna, and guys, I gotta remind everyone one more time, you have to ask your questions in the Q&A modules. There's too many of them coming in for me to be sifting through chat. So I ask you if you could just make the effort to put it in the Q&A module. So another really good question from one of our guests here. In viewing the program for chronic conditions, obviously much of the population has comorbidities, and the challenge of continuity of care and interoperability of data exacerbates the challenges of health equity. What are you currently doing to improve continuity of care and monitoring comorbidities and just providing overall holistic management of these patients? Do you want to take a stab at that first, Paula G?
Sure. Yeah, happy to. Thank you for that. Great question. So our kidney care program, so we have a number of different offerings, and one of those is actually a care management program that allows us to do that, right? And because we're of course part of the broader CVS Health and Aetna, we have access to predictive data to tell us, do we have certain members that are at high risk for CKD? How do we engage them before their chronic conditions get worse or they have other comorbidities that end up, being attached, to what they may already have. So, we have different levers that we can pull to try to address that and also even mitigate that before it gets much more complex for the patient to manage and of course much more costly. But one of our programs is our care management program, where we're able to really integrate all of these different parts that are currently very disconnected and siloed with other organizations or other segments of healthcare. So we can leverage all of the different touch points around care management to ensure continuity and address those those chronic conditions. And some of those are health hubs or minute clinics, our own pharmacies and using our pharmacists also as touch points for that. So we have a lot of levers that we can really pull to try to decrease that, and we do that through our care management CKD program.
Paula, Seun, do you want to add to that?
I was going to chime in. I think so. Everybody that we work with has a chronic condition. So we are sending our kits out to people living with diabetes or people living with hypertension who should be tested every year. So we know that going out, and we naively thought originally that we would get the result to the member and they would be so motivated because now they have some data. And we quickly found out, talking probably to our first health plan, that we had to find a way to close that gap. And it's really difficult because, no disrespect to health plans, but the data is not always up to date. So we don't actually get the right PCP lots of times. We don't get the right cell phone number. So we continue to look for ways and companies that have already done integration. So we can integrate into Epic and Cerner, but each health plan is different and different versions of Epic. And if they don't own the provider, then it gets complicated. So all I can say is that we spend a great deal of our capacity making sure that we do get, especially anybody with high albumin in their urine, because not only are they at risk now for CKD, they are at risk for a cardio event. So we will urgently get that back. If we can't get it back to a PCP, we get it at least back to the care management team that Paula is referencing so that they can be followed up. But it is, I think, still a problem nationwide in terms of how good the data is, how up to date it is, and how do we find the right people at the right time to get the data to. But we work on it hard, and we'll continue to work on that.
To Paula's point, I think that, for us as payers, right, we were dealing with a lot of imputed data because we did not have member reported data, which is the gold standard for race, ethnicity, language, sexual orientation, and gender identity. So to that end, now that we are receiving or will be receiving member reported data, I think that the data that is used that many organizations rely on the payer to give will be vastly improved. But for us at Independence, supporting our network, particularly our primary care doctors, because they are the gateway to identifying, managing, and mitigating these chronic conditions, is one of our main focus areas. Ensuring that those providers understand those patients culturally, that there is some sort of patient-provider concordance going on, meaning I look like my provider or my provider understands me, will help, again, mitigate all of these issues. Chronic conditions, rather.
It's great.
Eric, if I can add a point to what Seun just made, I think we all sort of struggle with data collection and how to do it properly. What's the right way to do it? I came from a healthcare system before joining CVS Health, and it's something that we struggled with. Who's the right person to ask this information, right? Because it's so important that you have someone that it's asked in a sensitive manner, that you're, and people then also don't know, what are you going to do with this data, and why are you asking me with, what this information? Why is this any of your business, right? So it really allows us to make better clinical decisions, but we need the right information. And we even struggle with that internally at Kidney Care with starting to accurately collect that information so that we have a better idea of what our members look like, because it allows us to really make the right interventions and measure it, right, and keep ourselves accountable and keep ourselves honest around the impact that we're making.
So, I'm going to stay off script here because there's so many good questions coming in from our audience, and there's a good one that just you teed up really nicely, Paula. So the screening programs that everyone is talking about has this equity lens. The question is, I'm gonna paraphrase it just to make it a little bit shorter, is how do you work with and train and or hire clinicians to follow up care, after these screening ops, that will also provide culturally sensitive care? Paula G, do you want to start? Take a swing at it?
I'll take a stab at that. That's a loaded question, right? There's so much that you can look at that. I mean, from we have a significant gap in this country with having enough physicians that are diverse, right? So, partnering with organizations that can help drive an increase in encouraging communities of color or historically marginalized communities to pursue a career in medicine. So there's a gap with the availability of providers that we have. And then I think the other component is then the existing providers that we do have, what tools do we use, or what education or training can we implement to make sure that providers are looking at their patients with that cultural lens in mind. I mean, so many individuals, especially historically, marginalized and disenfranchised communities have dealt with trauma, right? When you're coming into the patient room, whether it's in a community clinic or a healthcare facility, a healthcare system, understanding that there's so much more to that patient than their high blood pressure or their diabetes. So really having that cultural lens in mind and sensitivity, I think that's really the key, is that awareness and sensitivity to what the other intersections that this individual has, right? We talked about not just race and ethnicity, but sexual orientation, gender identity, lived experience, generational and age, right? The way that you're going to approach someone that's 21 is not the same way that you're going to approach someone that's in their 80s. And I think Paula might have made that comment earlier. So I don't know that there's an exact solution to it because there are so many moving parts that are going to help us do this a little bit better. But I think it starts with addressing and calling out those gaps and the need for us to do better and to do better for these individuals. But I think, collectively, by having panels such as these and partnering with the right individuals, we can certainly start to move the needle. I know with CVS Health, we are looking at under Dr. Janae Khaldun, part of her roadmap is around doing an assessment around cultural competency and sensitivity of the providers that we do have, and then upskilling them with ways in order to better address the needs of our diverse community across all the people that we serve within CVS Health.
I think our focus at Independence is to support the network that we have, and to Paula G's point, it is training them and hopefully helping them become more enlightened about the communities and the people that they serve. Because let's face it, to become a provider, whether it is a nurse, whether it is a physician, and that we're not even talking specialties, it can take anywhere from 4 to 12 years. So this is something that, our foundation has worked with universities to help fund and increase a diverse network. But this is something that is going to take years and years. And so starting with training, we have population health specialists that go into provider offices to help assist and to help provide insight. I think that is what we can do now as we look to the long term and helping increase the number of providers that are graduating from schools of medicine, schools of nursing, social work schools, et cetera.
Right. I was going to say, are IBC or CVS Health partnering with the medical schools at all around culturally sensitive, culturally competent care?
Yeah, we are. I think that our partnership with Temple, we are helping, we are actually paying, or the foundation is paying for students to complete nursing school. Our partnership with Accelerate Health Equity includes the Philadelphia, the School of Osteopathic Medicine. I'm sorry, that's the grandfather clock behind me. But yeah, we are definitely, we definitely recognize our partners in Philadelphia and to help us create a more diverse network.
Yeah, for CVS Health, under our Office of Diversity and Inclusion, there is a commitment as part of our social justice equity commitment that was made a few years ago. Part of that commitment is a partnership with historically Black colleges and universities, making sure that we're increasing kind of that diverse pipeline. But, even for us within kidney care, when we are bringing onboarding new talent into our organization, that is actually one of our pillars within health equity for kidney care, is that we reflect the community that we serve. So it's something that's very important to us, and it's on our roadmap to make sure that the talent that we're bringing in not just reflects the community from a race and ethnicity background, but a lived experience, right? Having individuals at the table that have had chronic kidney disease, whether they've had it themselves or have been a caregiver. We need those voices at the table to help us come up with the solutions for our members and our patients.
Great. We have 6 minutes left. I got a couple of important questions coming up, so we'll see if we can get through a couple here to get folks all the information that they deserve who've taken the time to listen. Quick reminder, folks, right now in your inbox is that email to take the survey. So maybe even while you're listening to the last 5 or 6 minutes here, you could take the survey and provide us that feedback that we're asking for you. It will be multiple emails if you don't, just to warn you. And I know you've gotten a lot of them from me already. So, all right. Paula, LeClair, how I want to get into some final things around engagement and follow-up and just communication. And how are plans gaining meaningful adoption of these technology devices in this last mile care, as far as communication methodology and distribution, messaging, packaging, et cetera?
Yeah, thanks for the question. So the communication is threefold. So we write the communication with the plan, and then we present to them what we've learned. So what we've learned from modality. Lots of times we might start with a plan saying, well, we don't text message our members, or we don't do this, or we don't do that. And we're able to show them data from other experiences with the hundreds of thousands of completed tests. So we'll work with the plan to come up with the right communication protocol. We are sensitive. They have other initiatives being launched. We don't want to step on anybody's toes. We don't want to confuse, that's the big word, we don't want to confuse the members about who's doing what. So I think the upfront planning on that whole communication protocol is key to the success. We will, in terms of closing the gap or how do we get data back, we, in some cases, have to still fax data. So if we're working with a plan and the best they can do is give us a PCP name and a fax number, we'll do that. So we will work with the plan and their network to figure out what is the best way. We would love not to do that, but we will do that if that's the right way. So I think that we plan and we'll work with the plan for what works the best for them. And then again, around the sense of urgency that this program is ending in 20 days or this program is ending in 5 days really drives up adherence. And we give all that information back to the plan. So we give them their learnings. We end up cleaning a lot of data. So we find PCPs that they may not have known the member has. We find better phone numbers. So I think the plans, in addition to getting all of their unscreened people screened, they're also getting back lots of information that we learned.
So Paula, how do you get those people though who don't trust the healthcare system or disengage? How do you get them back?
So we get them back. Again, first of all, I think the product itself is compelling. So I think having a test that I'm going to do in 5 minutes, I think it piques curiosity, and the early adopters are just going to go and do the test. So for them, getting the result back to their physician gets them back in the healthcare system. And then for those that need, we call them nudges, the folks that are, and again, just a reminder, when these are people that didn't test. So we're not trying to replace the 20% that will go to the lab. We let them go to the lab, right? We're looking for the ones that the health plan or the physician hasn't reached in at least 12 months. And so for those, it's again, finding out that this age group responds best to this message at this time of day, or email works better than fax or phone number, or a hard letter, a letter in the mail for this particular population is going to drive more. Is all of those go into play on how we drive that adherence.
Great. I'm hesitating here because I've got a couple more questions, but I know we only have 2 more minutes. So I think what I'm going to do, rather than risk going over, I'm going to close it up right now. I want to say to our panel, this has to be the record amount of questions that we took off script. And by the way, kudos to everyone listening live, because you asked some great questions. You were great co-moderators today. And so kudos to our roundtable of experts who were quick on their feet and really informative with someone thoughtful with their answers that they had no preparation for. So thank you for all of that. And to everyone listening, whether you're live or on the listening on the podcast, we like saying that we produce this show for you every week so that you get information that you could bring back to your peers and your leaders at your organization to drive meaningful change for your organization and provide better care for patients in our lifetime. And so I always like closing out the show with reminding everyone, thanking everyone and reminding everyone that this indeed is your Bright Spots in Healthcare podcast. Have a great rest of the week, everyone. Take care now.